Good morning, everybody. Uh, I'm very sorry that I'm a bit late because I was trying to connect from my laptop, but I think it's not showing that how I should go live. So I have connected through my mobile, and I I will be talking on the topic of Parkinson's disease, as has been mentioned in the schedule. And before that, I will take an opportunity to thank Dr. Ravindra Kumar Mudgil for inviting me on this platform of Haryana Chartered Association of Physiotherapists. And as well, I will also take an opportunity to congratulate him to be the president of Haryana Chartered Association of Physiotherapists, along with all his newly elected members, executive members. So I will be sharing my screen, and I will be sharing through my laptop. So just I will turn over the camera towards the laptop so that you all can see this. So I think it is visible to you. So my topic of presentation is Parkinson's disease and role of impact of artificial intelligence in Parkinson's disease. So what is Parkinson's? You all must be knowing that it is a problem of a brain, and what happens that there is a problem in movement of the subject, such as the movement will be not coordinated, it will be shaking, stiffness and difficulty with walking, balance problem will be there, coordination problem will be there, and Parkinson's patient usually have a very problem in their gait also. So if we see the gender wise, then we will see that more of men are more prone to the Parkinson's disease if we talk in the terms of percentage. And in many of the diseases we have seen that women are having less prone to those diseases, such as we have seen in stroke also, and the best example is the right now the pandemic going about the COVID, and the researchers has showed that 20% less it is in the women, and it is 20% higher in the men's, and so in this Parkinson's the ratio is 50%. 50% more men are affected with the Parkinson's disease, and it is known as disease of elderly. Onset of Parkinson's is around 55 to 60 years, and that category falls into the 90 to 95% of the category. Age category is around 60 years in Parkinson's disease. Early onset of Parkinson's is also there, that is around 40 to 45 age group category, and they are 5 to 10%. And sometimes nowadays, due to the pollution level or due to the stress in the life, and due to late marriage and all that, what happens that the around 1 or 2% juvenile Parkinson's has been also seen nowadays. Early onset of form for Parkinson's are often it is related to the sometimes it has been said that is related to inheritance and some form of the gene mutation, and mostly it is due to the dopaminergic neurons on which are secreting the dopamine, and in the basal ganglia substantia nigra pars sympactica, that area there the dopaminergic neurons are there, dopamine is secreted, it combines with the neuromuscular junction with the acetylcholine and then gives a coordinated movement. Kindly rotate. It is now fine. So dopamine is one of the main chemical which has the effect in the controlling of our movement. Okay. So now you are able to see rotated. I have rotated to 90 degree. Yes, Dr. Senthil, just give me a yes. Now it's fine. Is it fine? Yes, thank you. So Parkinson's disease have cardinal symptoms, means there are cardinal features in the Parkinson's disease, and that is the bradykinesia, that is the slowness of movement. This is known as the one of the negative feature in the Parkinson's disease, because what happens that the movement is slow, but it is known as it is known as positive feature, because the tone is there, even though muscles having increased tone in both group of the muscles, that is the extensor and the flexor group, or the agonist and the antagonist, but even though there is increased tone, the movement is happening, there is slowness in the movement, but the movement is happening. That's why bradykinesia has been said that it is a positive feature in the Parkinson's disease. Muscular rigidity is there. Muscular rigidity is known as the negative feature of the Parkinson's disease, because due to the increase in the tone of the muscles, due to that rigidity, which is increase in both aspects of the muscle group, that is the agonist and then the antagonist, what happens that it restricts the movement, frequent movement, and that's why the Parkinson is also known as one of the movement disorder. It is known to be as movement disorder. Then there is a resting tremor. Resting tremor is also there in the patients with the Parkinson's disease, and two types tremor you can differentiate. One is the resting, another is the functional. In resting tremors, what happens that while the hand or the limb or the body is in rest, then the tremor will happen. As soon as the person becomes functional, or he will start functioning with the hand, then what happens that the tremor disappears. So their functional tremor or the resting tremor. I'll just show a video that will clear one picture regarding the functional and the resting tremor. Not having right now. Okay, I'm not having in this. Just afterwards I'll show it to you. So then postural instability is also one of the cardinal feature in the Parkinson's disease. Postural instability is due to the increase in the tone of the muscles, and what happens that the trunk or the body stoops forward, and then slow step gait is there. This leads to the postural instability. The function of the hands get limited, the movement of the hand gets limited, and this leads to the frequent fall also. So due to the postural instability may lead to the fall also. Then other symptoms may be like that the subject is will be speaking very softly, his expressions will be not as much as normal people. The expressions are as such that it looks like face, mask like face is there, so expressionless face is there. So these are the one of the features which can be seen in the Parkinson's patient. then as we all know, or the students are here, then they should know that the Parkinson is a progressive disorder, means it progresses with the time. With the exercises, with the medicines, we can delay the progression, but the progression will be there, hence it is also known as progressive movement disorder. So we can delay the progression, and suppose a subject is having some functional outcome which is very low, then slowly and gradually his functional outcome will decrease, but with the physiotherapy and the medicine we can delay it for years, and we can help the subject to lead a good quality of life. So many people of Parkinson's, if we talk about the early sign and symptoms, then they will experience stiffness, tremor, the sleep problem is there, constipation, decreased ability to smell, and restless syndrome is there. Parkinson's has been divided into the stages, that there are 5 stages in the Parkinson's disease, and it has been done accordingly to the functional aspect, looking into the functional aspect of anybody, and then this has been divided into the stages. So stage 1, where the symptoms are there, but the subject is able to perform his task without any much of the interference, means though he will be having little bit of difficulty, but he will be performing his all of the task with some amount of interference in his daily activities. So you can say that this stage of Parkinson is known as can be termed in stage 1 of the Parkinson's disease. So then another one is the stage 2, where what happens that the length and the duration of performing any task increases. When suppose for example what happens that one subject is taking, a normal subject takes around 4 to 5 seconds to get up from the chair. Here what will happen that he may take around 1 to 2 minutes to, or more than 2 minutes to get up from the chair. So the length and the difficulty has increased, though he is able to perform the task, but performing of task has gotten worsened. Tremors, rigidity, movement, or the side walking problem in the posture is apparent, and that can be seen, and the task performance is lengthy and difficult. So this is stage 2 of the Parkinson's disease. Then is the stage 3. It can be, it is also known as the mid-level of the Parkinson's disease, where what happens that loss of balance, slowness of movement is more apparent, fall becomes common, but still the subject can live independently, but some amount of task he will need some assistance. So you can say that most of the task he will be doing independently with increase in the length and the time, but some of the tasks, some fine movements like dressing, eating, or doing some other movement, he will need some assistance. Even suppose he is able to sit from sitting position, he is able to stand, but what happens that while walking he may need some assistance. So you can say that this is stage 3 of the Parkinson's disease. Then is the stage 4. Stage 4, what happens that the clinical features and the problem in performing any task becomes very limited. He needs assistance to perform any other task, either from sit to stand also he will need some assistance, from walking also he will need some assistance, while sitting also he will need assistance, while lying also he will need some assistance, getting up from the bed he will need assistance. Though he will be taking his effort, but without assistance it will be little bit difficult for the subject to perform any of the ADL. That's why we can say that this is stage 4, where in every task he needs amount of assistance by any person, or by any orthosis, or by any object. Then we can say that the stage is stage 4 of the Parkinson's disease. The stage 5. Stage 5 is the most advanced stage, where there is stiffness in the leg. It becomes very impossible for the person to sit, stand, walk. You can only say that the patient becomes bedridden. and he needs nursing around the clock of the around his to around his him or her to perform the ADL. So there are some non-motor movements also with the in which we can get to the conclusion that the subject may have the Parkinson's disease. And non-motor functions in Parkinson's disease is generally the early sign of the Parkinson's disease, and when these signs are seen, we can immediately see a doctor and we can get it diagnosed as early as possible, because as early as that possible the diagnosis will be there, then there will be more delay in the progression of the disease. So the cognitive changes are there, the non-motor functions changing, our cognitive function, the attention, planning, language, memory, everything is the problem persists. And yesterday I have seen that Dr. Varis was talking about this, the low mood and all that. So these things do occur in Parkinson's disease also. Constipation is there, then early feeling of fullness, and very small meal means he will not be eating properly. Excessive sweating is there, fatigueness will increase, loss of smell and taste is there, mood disorder is there, like depression is there, anxiety is there, irritability is there, sleep disorder is there, sexual disorder is there, urgency, urine urgency, incontinence, frequency, increase in the frequency, vision problem, weight loss. These are the non-motor functions of the Parkinson's disease, which can be seen closely by the relatives or the friend in order to get the subject early attention regarding the treatment. So there is one more scale to define the functional assessment in the Parkinson's disease, and that scale is very important in Parkinson's disease, and it is a very vast scale, very big scale is there, and it has covered nearly all the functional aspects, right from the mental to the physical to the gait and all that. And this scale is known as UPDRS scale, that is the Unified Parkinson's Disease Rating Scale. This is one of the most important tool in Parkinson's disease to judge the subject functional outcome, and accordingly we can plan the treatment, and the outcome can be judged in a better and finer way. So one who is there, then here, then they can go through that in detail, that UPDRS scale. Unified, U stands for unified, P stands for Parkinson, and D stands for disease, R for rating, and S for scale. So UPDRS scale has been divided into 5 parts. The maximum number here in UPDRS scale is 199. If one is able to score 199 with the symptoms of the Parkinson's, then we can say that the subject, though, is having a difficulty in performing the movement, but his functional ability is very good. And one who scores 0, then we can say that the functional ability of the subject is very poor. So 0 to 199, 199 is good, very good, excellent you can say, and 0 you can say it's the worst scoring in the UPDRS scale. So what happens that if we go through the UPDRS scale, it has been divided into 5 parts, right, starting from the 0. If he is doing some movement with the symptoms, then you can term it 0, or the description wise it is normal. Mild problem is there, is the reduction in the amplitude is there while performing those tasks which has to be asked in the form of questionnaire, then we can rate it as 1. Moderate impairment is there, the early fatigueness is there, occasional arrest is there, or you can say freezing of the movement is there, then we can judge the subject as or rate the subject in UPDRS scale as 2. 3 is severely impaired, frequent hesitation, initiation of the movement or arrest on the ongoing movement is 3, and if he is not able to perform, it can be rated 4. So 5 ratings are there, and overall of rating is 199. So theory about this Parkinson's is that how it happens that in the nervous system it affects the dopaminergic neurons in the cortex over the time, and what is that the Lewy bodies are there in the that area. That Lewy body are the bad protein which gets accumulated, and then it leads to the impairment in the release of the dopamine chemical, and that leads to the movement disorder, means impairment in the movement. So other symptoms like tremor, loss of smell, constipation, this we have talked it about. So now we come to the physiotherapy management. In physiotherapy management, what we see that we work on neuroprotecting, focusing on endurance and use of the motor learning principle approaches such as mental, imaginary and dual task, because what happens, the dual task performing in a subject of Parkinson's becomes very tough. Suppose if you are asking a person of Parkinson, you are asking to do the gait, and suddenly if you will ask him that what is 5 plus 3, add it, then he will start fumbling, because he may not perform the dual task. He can concentrate only one task which he is doing. So we have to slowly and gradually progress towards the dual task performance in the subject, so that he becomes more have a very more coordinated movement. And for that intensive and extensive physiotherapy should be given to the subject who are suffering from the Parkinson's disease and having difficulty in performing the dual task. Physiotherapy undertaken in a group also, and it has been seen that it is very beneficial in the subject who has taken in the groups, because what happens, they do interact with them, intermingle within themselves. This gives the psychological boosting also to them, and they feel much better and they perform better in the groups also. So when we talk about the medical treatment in the Parkinson's use is generally given by the physicians, and it depends upon the investigations, what investigations they have done, and what level of Parkinson's they do diagnose it, and accordingly the drugs doses are set. And it also depends upon the rigidity of the muscle, it also depends upon the freezing of the movement, it also depends upon the akinesia movement, means involuntary movements are there. So these things has to be taken into the account, and then accordingly the doses are set, whatever drug is to be prescribed to the subject of the Parkinson's disease. And then we can drugs to control the motor. And then one surgical process is also there in Parkinson's patient, that is the deep brain stimulation. Also in short form it is known as DBS. DBS is generally formed in a stage 4 or 5, you can say, those subject of Parkinson's disease, those who are in stage 4 or 5, or they are having akinesia, severe akinesia in the Parkinson's disease. Akinesia is an involuntary movement. The subject will be moving his hand, leg, body in such a way that he is dancing. So akinesia impairs the lot of movement in the subject. So in these cases deep brain stimulation can be given, and deep brain stimulation is a surgical process. Why it is important in terms of physiotherapy? Because when one thing is more in medicine as well as DBS, there is on and off phase in Parkinson's. So on phase is that when a drug is being administered, or suppose DBS has been installed, then what happens, that the subject symptoms disappear. So, and it disappears with the medicine. When the medicine is there, it disappears with the medicine for certain period of the time. Suppose the effects, and it will depend upon individual to individual. Somebody may be having 2 hours effect of drug, 3 hours effect of drugs, other may have 6 hour effect of the other person may have 8 hours effect of the drug. So as the drug is their effect of the drug is there, symptoms are decreased, and when the symptoms are decreased, then that phase is known as on phase. So the drug is acting, then it is known as on phase. As the drug starts wearing off, then it is known as off phase. So off phase is the drug starts wearing off, and in off phase what happens, the symptoms do come back, and especially it happens with the medicine. In DBS there may be effect more longer effect is there, but we have to coordinate with the on phase and off phase, because what happens that at that period of time in on phase, if we are giving the exercises, then that will have more beneficial effect on the muscle mobility, joint muscle mobility and flexibility, joint stiffness decrease will be more, so effect will be more. And if you will see give it the treatment in off phase, then what happens that it may lead to some other fatigueness and all that, with the soreness in the muscle group, because already the muscle is tight, stiffness is more. So at that time we should try to avoid it and try to coordinate with the on and off phase of the Parkinson's disease. So as I was talking about the DBS, so in deep brain stimulation, our surgical process, there what happens that electrode is implanted in the brain, and there are small electric devices implanted in the chest, and the programming is done through the remote control by the physician. It is involvement of the neurosurgeon as well as the neurophysician, and the programming is done. It takes around 1 or 2 weeks to do the programming until the effect is there, till the progression delays, till then it works. As it is a progressive disease, then when he comes back after a year or two, then new programming is to be set on these patients. So DBS is also one of the thing which can be done in the Parkinson's patient. When we talk about the physiotherapy management, why it is done, then it is done to maintain the musculoskeletal flexibility. Thoracic expansion is important because stooping of the posture is there, and due to stooping of the posture, the vital capacity may decrease, the muscles, diaphragmatic muscles, the respiratory muscles not work up to the mark, so it may lead to the deconditioning of the chest. We have to prevent the psychological decline also, because the person is depressed, and with the exercises what happens that adrenaline, epinephrine, serotonin, these chemicals are secreted, and this do help in preventing the psychological decline. We have to encourage the subject to live the active life, because as far as he will live the active life, that progression will delay. We have to prevent the contracture, deformity, stiffness of the joint. So more important thing is that we have to work on the mobility, flexibility, increase of the strength, gait, aerobic capacity, and that definitely will lead to good quality of life. So I will also explain some exercises. I have made some video of the exercises to improve the endurance, generally what can be helpful, and for the balance also. So balance exercises is also very much important. So we will start with the balance exercises. That what are the balance exercises apart from the Frankel exercises which can be done in order to improve the balance. So just I will playing a video.
Prabhat, physiotherapist, will be demonstrating you balance exercises for Parkinson's disease. As Parkinson's disease patient face problem in balance, and these exercises are very much helpful in balance retraining, which may help the subject of Parkinson's disease balance themselves and have a better coordination and prevent from fall. This is the first exercise in standing position. For this, we can keep a chair nearby also when the balance is not proper. So we can keep a chair, or we can do it without the chair also. The first thing is that standing upright with the feet apart and the face facing forward. Stand in this position for 30 seconds, and then again we can make our feet close and stand upright for 30 seconds. If we face difficulty in doing this exercise, we can take the help of the chair. We can stand with the feet apart for the 30 seconds, and then with the help of the chair, support of the chair, we can bring our feet together, and then again stand for 30 seconds and try to wean off the support of chair slowly and gradually. This exercise is with making the feet forward for the balance, and this should be kept in such a manner that the leg should be touching the heel of other leg. Just we can see like this, and we can stand for
This is the modified tandem. We can start with this.
Again, the left leg
Then left leg we should take.
should be in front of the right leg, touching the toe of the right leg with the heel of left leg. If we face problem in doing it independently, then we can take the support or the parallel bar should be there, and that parallel bar also we can take the support. With the chair, the hand on the chair, and then we can bring forward our limb to the other limb. Then again holding for 30 seconds, then the next leg in front. First we should start with the support exercise, and then slowly and gradually progress to the independent exercises. This can be performed in dynamic way also. For dynamic way, it is known as tandem walking. So we can put a bar, and then we can put, suppose right leg we are taking into the front, it will be touching the toe of the left leg, heel will be touching the toe of the left leg, and then again we will move forward. This is known as tandem walking. Without support also we can do this. Take the right leg in front of the left leg toe. The heel should be touching of the right leg with the toe, and then again.
This is the dynamic tandem.
This we can repeat for both the right and left leg. Next is the single leg stand. I am showing first the modified way how we can do.
This is the modified single leg stand. If the person is not able to stand with the single leg, you can modify it by putting a stepper ahead. So put the one leg ahead.
30 seconds, and then we can take down the right leg, then we can put the other leg on the stepper.
So 30 seconds we should keep it.
This is the modified way, and this we can repeat for 10 repetitions. The other way of doing this exercise is single leg standing.
So now the single leg standing for the balance.
We can put the leg on in the air as much as it is possible. Minimum 30 seconds it should be kept with the right leg and as well as the left leg. Next is lateral balance. For this exercise, sitting upright, hold the legs apart, and then we can take the right leg as far as we can take, and then we can come back to the starting position, and again we can go as far as we can take the other leg and keep it.
So take the leg laterally, either right or left, as far as you can, and then we can come back to the starting position.
Come back to starting position, doing 10 repetitions.
This we can do with the support, standing against the wall also.
Next is the backward walking.
So backward walking.
Modified as well as dynamic. In modified backward walking, we can take our right foot backward for one step, first putting the heel down, and then
Coming back to the starting position.
Then repeat it with the other leg. This can be repeated for the 10 repetitions. This is the modified backward walking. We can backward walk.
So we can start with the modified, and then we can progress to the dynamic backward walking.
Again we can see this, how the backward walking can be done. Backward walking with the other leg, and then this may help you in getting the balance of the exercise. This is the forward step. You can take
So then is the forward step.
ahead of one leg, and right leg I am keeping, and come back to the starting position. Then same we can repeat with the other leg, that is the left leg, and then we can come to the starting position back, and this can be repeated 10 times at a time. Next one is the quick step.
Quick step is one of the important things.
When there is sudden shift in our gait, suppose we are doing it for forward bending. When we are walking forward, then suddenly we fumble up and then we have a fall. So this can be also practiced, because in patients with Parkinson they are not able to take quick step. So how to take the quick step and develop this coordination. First, on the forward, we can see that we will shift our body weight forward.
So shift the body weight as the field and take a quick step.
One leg ahead.
So this will develop a habit whenever the chance of falling is there.
Take the body weight forward. As we will fall, we will take it other leg also forward. So this quick step will help us in balancing while we are moving forward. Then the lateral, to have the lateral quick step. So we will laterally shift the body weight, and as
we feel that,
and ask the subject take the one leg apart from the other leg. So this hold for 3 seconds, then come back to starting position, and again for the other side as we are falling, we'll keep hold for 3 seconds, and again on the starting position. We can repeat for 5 times. Next is the dynamic balance exercise. This dynamic balance exercise,
this is walking in figure of 8.
Figure of 8 structure. You can put 2 blocks in front and make the subject walk in a figure of 8. Suppose he's walking, he can take these steps and make a figure of 8 and coming.
So you can put a 2 block and then ask the subject to walk in this manner, and figure of 8 manner. This also improves the balance in the subject.
Apart from these dynamic exercises, this figure of 8 exercise, we can do more of the dynamic exercise to improve the coordination and the cognition also. This was the motor training for the coordination, but for the cognitive also, we can ask the subject while walking, he can subtract 5 plus 3, 5 minus 3.
While walking also cognition is to be improved. You can give a ball to him while walking to catch, to do the calculations in the mind, or he can take his mobile also, do some activity while walking on the mobile. It is not prescribed either way, but just to improve the coordination it is being done. So these were the exercises for the balance, apart from the Frankel exercises which can be also done. And then I'll demonstrate some strengthening exercises, that how it can be done in the patients of the Parkinson's. So I will be explaining the exercises here. Just so for starting the exercises for this training, or to increase the endurance, it should be seen that the muscle doesn't get fatigued. That is very much important. And we can do the exercises as not every day, but also in the gap. Do on Monday, then Tuesday give a rest, then Wednesday, so that the proper rest of the to the muscles also is there. So we should take a rest in between. I will just forward it by. So first is sit to stand. Take the chair, and the chair, see that chair is very stable. It doesn't slip. So initially, with the help of the armrest, with back supported, the subject should sit, the Parkinson patient, and then with the support of the armrest he should try to get up. In starting, initially we can do with this. And this can be done in the sets of 10, 10, then rest, then 10, then rest, then 10. So with the support of the armrest, get up, sit, stand up, then support of the armrest, sit down, and then without after the repetition, without try to get up without the support of the armrest, and try to sit down without the support of the armrest. So slowly and gradually we can progress without any assistance.
Without the armrest, help of the armrest, then sit without taking the help of the armrest. In this, we can adjust the height of the chair.
So we can adjust the height of the chair in order to improve more endurance. We can start with the higher, we can put it the higher level, and then slowly and gradually we will take it the level down, so that the endurance also increases, as well as the coordination also improves in the subject of the Parkinson's. So we should lower the chair. Then is the heel and toe raise. First we can start with the with help of the chair.
The chair should be firm on the ground, it should be straight. Stand upright.
So we can stand up, we should so that subject should stand upright, and then goes on his toes, and then come back to the starting position, and then he can go on to the heel, and this can be repeated 10 times.
Down, take a rest, again 10 repetitions, then take a rest, again balance.
So now is the lateral standing, lateral with standing. So lateral for to keep a stepper. Put your one leg on the stepper, and with the help of the body weight and the your endurance, try to get up. Hold in this position for 10 seconds, then come down. So this will also improve the endurance of the lower limb, and this can be repeated for both the right and left leg in the sets of 10-10.
This exercise independently, as there are some stages in the Parkinson, stage 1, stage 2, stage 3, stage 2 or 3, sometimes may need some support.
So if we are not able to do independently, then we can take the support of the chair or the wall, so that with the help of the chair or the wall or anything is available, we can take the support. Even of the table also, even of any sidebar also, even of this table walker also. So take the half squat.
The leg little bit front, and then the help of body which is upright.
So just I will wait. So let some join those who were joined, because some technical error came. So this exercise is half squatting exercises with the help of the wall in order to get the coordinated movement. So stand against the walls upright, and then we can start. So now we'll start. Let the people join.
And is touching the wall, just slide down, and it should be as such that it should not cross over your toe, greater toe. It should be near
So
the
it should
toe.
not cross over the toe. So sit in such a manner that it should not cross the toe. It should be in the line of the toe.
So get down, then up. If any problem in doing independently, you can take support of the wall.
Then support can be also taken to perform this exercise.
Up, down, go up, go down. This also 10 repetitions, take rest, then 10 repetitions, take rest, then 10 repetitions. Back, the middle of the TheraBand doesn't get.
So now with the TheraBand,
Make sure that it is
so TheraBand should be kept in such a fashion in the hand that it should not slip, and keep the TheraBand tight. The tension should develop.
between tension is developed. So now I think that tension has developed. Take the flutter part.
So the flat part should be kept underneath the toes.
And the tension is developed.
So tension is developed, so you can do it for the upper limb, for the deltoid also, for the elbow also. So what I am doing, this is for the flexion, as well as I am squeezing my both the scapular blades, contracting both of them, and this will help us in opening my chest up, and then extension.
Strengthen the upper muscles.
So this way we can do flex it, and then opening of the chest, extension of the shoulder, and then the scapular blades are coming together, closer. Then another one.
Strengthening, put the theraband middle so that it should not slip. Put your hand straight, and then slowly.
So for the deltoid we can take the
90 degree straight
abduction, we can do both the hands.
Straight and down. Other hand straight and down. It should be done 10 repetitions, but if you are any of the subject is not able to complete the repetition of the 10, then 5 sets also can be done. Then further we can proceed bilaterally also. Put the band underneath your foot.
So bilaterally also we can do.
Bilaterally we can proceed. Then we can also do it for the elbow.
So for the elbow flexion,
Tighten the grab hand, and then flex your elbow, straighten up, flex your elbow, straighten up, flex your elbow, straighten up. Same this way, flex your elbow, straighten up, flex your elbow, straighten up. This can be done 10 repetitions. Not able to perform, then make a set of 5 also. Go that slowly and gradually. The subject can progress in certain repetitions. So now for the strengthening of the lower limb.
so for the lower limb
Muscles of the
we can tie in.
lower limb of the right side. How we can the theraband should tie it over the leg which you want to strengthen.
So tie,
Such a manner.
suppose you would want to strengthen the hip flexors, then tie in this way.
Then the other end should be at your
So maintaining the tension of the
put it in the middle
theraband.
in such a way that the tension is developed here. So put it here. You can either you can hold with your hand or you can just put it underneath the chair. Hold it firmly with this leg and then lift up and down. Lift up, down. Lift up. 10 repetitions. This leg and the 10 repetitions after tying the same manner. This leg and in that set and do it for 20 repetitions in that set of the leg. Then this exercise can be done in standing position also. Tie this, just this is for the illustration, leg which we want. So this surface should be hard.
So for this way we can tie it to the chair, and it should be very firm. See the chair, and then for the hip extension and the flexors we can do abductors for both the sides. We can do this exercise in the Parkinson's disease.
Stand upright, one by one, 10 repetitions.
So 10 repetitions can be done.
Start with the low resistance band.
So these are types of the band which can be used. Green one is the low resistance, and yellow is most low. Then is the yellow, and then अब चालू हो गया. हाँ आ गया. So sorry, network problem is there little bit.
And this restricts the movement, so we can do the stretching, a very simple stretching exercise.
So stretching exercises can be done.
Lie on the mat. Lie on the mat. Flex both the knees. You have to flex both the knees. And when we are rotating the lower limb towards the left side, our neck should go
So stretching is very important, because what happens, the trunk get stiff, and the posture is stoop. So we should do this stretching, and that simple stretching exercise can be done, and then later on take the hand overhead, and then this will also open the thorax, and try to maintain that the scapula is touching the ground fully. So after that you can do the stretching exercises. So these all were the exercises which we can do, and then this will help the subject to delay the progression, as well as to lead the good quality of life in the subject of the Parkinson's. So these type of the exercise, and definitely it helps in maintaining the mobility, flexibility, increase the strength, increase the gait speed, increase the aerobic capacity, and ultimately the aim is to make them lead a good quality of life. So it helps in making them a good quality of life. That is the recent advancement. The other part of the talk is the recent advancements, which is there now in the form of artificial intelligence or virtual reality. Because and now in this pandemic, these things are will be very much in demand also, and late after this also, this because this is going to last for long, though tele-rehab, telemedicine, telephysiotherapy, these things will be increasing, and it is increasing. People have started teleconsultation nowadays. We can see that most of the therapists are advertising that we are having a teleconsultation, telephysiotherapy. So this can become a very much helpful in coming days. So computer science defines artificial intelligence: any device that perceives environment and takes into the maximum chance of successfully achieving its goal. So it is a type of a device which which interprets the external data, and internally accordingly the a task is being given, which helps in maximizing our you can say functional ability. So this is known as artificial intelligence. We go to some characteristic definition, that is a system ability to correct interpret external data, to learn from such data and use those learning to achieve specific goal and task through flexible adaptation. So before going to this, how it has been helpful, many of the tests has been done, pre and post treatment, pre-treatment, post-treatment. The test should be performed is the Burke's balance test, time up and go test, that is also known as tug test, UPDRS scale, functional assessment, gait assessment. This should be done, and then we can see that the subject is having the good improvement. Here I will show you one video also. Before that, we can see that this is a picture here. This is of a gait lab, where a subject through artificial intelligence and the virtual reality, how he or she improves the gait number. You can see the numbering here. These numberings are here, and these numberings are indicating this is a treadmill 6x10. Number 2 is the 8x8 rear projection. You can see these are the these three are the rear projection. You can screen, which gives gives a perception to the subject that he is walking on a normal surface, though he is walking on a treadmill, but he will feel that he is walking a normal garden or anything where even surface is coming suddenly out, suddenly, or the plain surface is coming. So accordingly he will be feeling. Then cameras are there, 4 cameras are there. This is to record the gait. And then safety harness. Initially we can begin with the harness, so that the subject is not having fallen. Slowly and gradually, as the he improves in his functional outcome, then the harness can be weaned off. So I will show you video of this. A very good video is there. So you can see lady is there. She is walking with the harness, and she is doing performing a dual task also in the meantime.
Is buckled up and ready for action. It looks and feels like she's part of a video game, but it's actually high-tech rehab for her.
So she is walking on a treadmill, but as if through the projection, she is feeling that she is walking on a surface.
Very safe environment for
So now she is doing dual task also. You can see she is hitting a bird.
And a base that moves to mimic different surfaces. It can also react and adjust to a patient's movement, and a wraparound video screen completely immerses the patient into a real-life scenario.
When I go over like a little hill, you feel it in the machine.
Rather than just having the patient walk or an individual walking up and down a standard biomechanical track, now what we can do is we can change the environment in a very dynamic fashion.
Special programs are designed to work on specific skill sets while providing positive feedback. During weekly appointments at Cleveland Clinic, Sandy works with her therapist on gait and increasing stride length by touching her toe to a box.
So it increases the stride length slowly and gradually in her. And now she will be hitting the bird also. So while walking, she is doing the dual task, the progression.
Swatting them down and killing them. Not that I enjoy the killing part, but I do enjoy the challenges. Can I get them? I know once I slow down, they can come from where I couldn't move. So I'm willing to do whatever I can.
So now you can see she is walking without the harness also, and she has improved her gait also. So this has helped her in the gait. So with the dual task, as you have seen, that she was also in between performing the dual task. All right. So I'll show you one how this works. These are artificial intelligence and everything works. So I can show you one video. There are accelerometer, gyrometer, manometer. These things helps in giving a good interpretation in the Parkinson's disease. And this works, how it works, that all we know that brain is a plastic organ, and as per the feedback, as per the practice, as per the repetition, the brain adapts to that. So it is said that use it or lose it. When you will use it, then you will gain it, or if you will not use it, then you will lose it. So we have to keep practicing the things. The brain adapts to that, and then that delays the progression and helps in leading a good quality of life. So another video is there. You can see that how this works. These artificial and virtual reality works. There are certain things behind that which will help you in getting an idea. So this lady, she is doing physical therapy with the help of the virtual reality as well as the artificial intelligence.
Like most Parkinson's disease patients, exercise eases Mary Spletter's tremors, halted gait, and lack of balance. She recently took part in a UCSF study to see if special video games could replace her regular exercises. The therapeutic games are the result of a marriage between game developers and scientific researchers.
Well, UCSF had developed a series of exercise programs for patients with Parkinson's. And they asked us if we could actually make a video of it. And we said, you know, there's this new thing called the Wii. Why don't we make interactive games?
UCSF researchers thought video games might be a welcome change of pace from physical therapy, which can be tedious.
People very much like doing the games. They found them engaging, fun, and therapeutic.
But developing games that would know if patients were using the right muscles in the right way was tricky.
So the external data is interpreting that, and how the sensor worked, you can see in this.
So there's three different devices that you need to be able to sense where you are in a particular space. One is an accelerometer. Am I moving?
So accelerometer is there, gyroscope is there,
gyroscope, which is which
magnetometer is there.
And then third, you need something like to say, okay, I need a rock solid north, and that's a magnetometer.
These three technologies enable smart devices to do this. To make the technology more accurate, the developers created suits with 9 built-in sensors.
They were a big pain.
The battery-operated suits were awkward and cumbersome, so the developers turned
So
to
these are the
camera
sensors,
technology.
these are wire sensors, then this is the wireless sensor.
Taking that information and using some
So how it is the external data is being interpreted.
The camera technology does not need to be worn, but it's not as accurate as the sensors.
Each one has their pluses and minuses, and we're looking at actually trying to perform a fusion between those two technologies.
The UCSF study showed that despite their physical limitations, Parkinson's patients could successfully play the games at home. And they did them more often because they enjoyed them and they helped.
It was a fun way and an easy way to exercise right in my own front room at any time. I felt better. I felt more normal, more fluid, looser.
In fact, the study found that after playing the games for 12 weeks, 65% of patients had
So this
longer
has helped
strides,
the subject, so they have
55% had
improved
increased gait
the
velocity,
gait
and
velocity, is
55%
improved stride
also
length,
reported
improved the
improved
balance. So this was helpful
The hope is that if
in
we
getting
can
the
engage
treatment
people in
of the
physical
Parkinson's
activity early
disease
the
in terms
disease
of
course, that we
progression.
might actually be able to delay progression.
The therapeutic games could be available to the public as early as next fall. For Smart Planet, I'm Sumi Das.
So this way you saw that how this works with the sensors. So sensors are there, and apart from this, devices to have the measuring of the tremors to the of the gait and everything is coming. Here you can see that this is a device like smartwatch nowadays is there. So this device measures the tremor, that in a minute how many tremors are, how much tremors are there, and accordingly with the treatment how much it decreased or how much it increased. So it helps in designing the treatment also. So this is the device which can be put and this can assess that how much of the cadence was there, the stride length, whatever the speed gait and everything can be discussed in this thing. So these are the artificial intelligence making much more, bringing much more accuracy into the treatment, and by developing the research protocol, this will also help in developing the research protocol for our therapists or the researchers of in the field of physiotherapy. So these things, as well as for the diagnostic tool as well as for the therapeutic tool, this can be used for in the coming future, and it is being used. So with the advancement of technology, measuring of Parkinson's in rehabilitation will grow significantly, and the better outcome will be there for the patient to lead a good active quality of life. So thank you everybody. This was my presentation all about. So any queries there? So in between little bit there was a technical problem due to connectivity of the net. So any question is there, then you can ask to me. No question? Thank you. Any question is there, just you can ask. Yes. So should I leave? Yeah, Dr. Mudgil, Dr. Senthil, Dr. Manoj, what is your viewpoint in this? Should I leave this page or wait for some questions? So thank you everybody. I think no questions are coming up. Thank you for inviting me, all the team of Haryana Chartered Association of Physiotherapists. Thank you.